We're going to enter into some pathology of the nervous system, looking first at neurologic vascular disease and starting with cerebral infarction. This is an ischemic stroke, which it leads to brain tissue death due to an interruption in blood flow. And the cerebral infarction, then, by definition, would be an area of necrotic brain tissue resulting from blockage of blood flow. There's a couple different causes of obstruction, thrombosis or embolism. Thrombosis is a local blood clot that formed within cerebral arteries, oftentimes due to atherosclerosis. An embolism is a clot or debris that's traveling from another part of the body. This could be from the heart via the carotid artery, and lodges in more narrower cerebral vessels. Some other common obstructions include atherosclerotic plaque rupture, cardiac thrombi, oftentimes from AFib, atrial fibrillation, or a fat, air, or septic emboli, which is less common. Looking at specific arteries that can cause issue, our middle cerebral artery infarction can affect the lateral geniculate nucleus and optic tract. That means it's going to affect ipsilateral, same side, nasal visual field fibers, contralateral temporal visual field fibers, and contralateral homonomous hemanopnia. That's what we would call it, essentially. So when we're looking at a middle cerebral artery territory, it's this kind of area in red that we're seeing. Middle cerebral artery infarction affecting the temporal lobe can lead to optic radiations being affected. Includes Meyer's loop, which is an inferior bundle that contains same side superior nasal visual field fibers and opposite side superior temporal visual field fibers. We would call that then contralateral superior homonymous quadrant anopnia. Hard to say fast. And then our parietal lobe, we can have our optic radiations affecting our superior loop. This is the superior bundle containing same side ipsilateral inferior nasal visual field fibers and opposite side posterior or contralateral inferior temporal visual field fibers. We call this contralateral inferior homonymous quadrantenopnia. Looking at a posterior cerebral artery infarction, this really is going to affect our occipital lobe and visual cortex. The projection kind of visual issue will then be ipsilateral nasal and contralateral temporal visual field fibers. And then we see this contralateral homonymous hemanopnia with macular sparing. And this would be an example of homonymous hemanopnia contralateral, so here and here, but then we have sparing of the macula. Looking at some other issues, if you have an infarction in the cerebellum, we can see centralized vertigo. So that would be a sign that the cerebellum has received an infarction. Another word for stroke is cerebrovascular accident. And this is a sudden disruption of brain function due to a vascular cause. CVA refers also to a sudden loss of neurologic function due to disturbances of blood supply to the brain, and we can classify it as ischemic or hemorrhagic. If we're going to put it into buckets, our ischemic strokes, we can kind of look at thrombotic, embolotic, lacunar, and hypoperfusion. If we're looking at our hemorrhagic, we can kind of look at location-wise subarachnoid, other intracranial regions like hematomas, interparenchymal, lobar lacunar, or interventricular. An ischemic stroke is much more common, and it's due to obstruction in cerebral arteries, due to thrombosis or embolism. It can lead to what we looked at first, a cerebral infarction or tissue death or necrosis. A hemorrhagic stroke is less common. It's caused by rupture of a blood vessel, oftentimes leading to intracerebral, inside the cerebrum, or subarachnoid bleeding. And this is most commonly associated with hypertension, also aneurysms or trauma. Some upper motor neuron signs to watch for CVA includes hyperreflexia, hypertonia, spasticity, and Babinski's sign, which is an upgoing plantar reflex. If we look at what does the stroke look like from a histologic perspective, it's liquefactive necrosis. Hypoxia for 4 to 5 minutes or more leads to an irreversible injury, this type of necrosis. Our neurons become irreversibly damaged. Hydrolytic enzymes from lysosomes lead to necrosis that occurs over weeks, essentially digesting the tissue. Our microglial cells will then come in to break down kind of the junk, leading to these cystic spaces that are surrounded by gliosis. And this happens over the course of months. So if we're going to watch the time post-injury of stroke, 1 hour post the initial inciting event, we would see failure of our ATP-gated ion channels and leading to increased glutamate. Histologically, really not a lot of change, maybe some intracell edema, cytotoxic edema. Within a half a day to a full day, 24 hours, we would see activity and dissolution of our Nissl bodies and irreversible chromatin condensation, showing that we're starting to see damage within our nucleus and our DNA. In the red neurons, we would see eosinic cytoplasm, so loss of Nissl cell bodies or Nissl bodies. You also could see pycnotic nuclei, which are really small, dark staining nuclei. Within 1 to 3 days, you'll see invasion of neutrophils, and that will disrupt the tight junctions of the blood-brain barrier. And this is where we'd see our liquefactive necrosis, increased neutrophil density, and even some vasogenic edema. And up to a week, we'll see now macrophages and microglial cells coming in to phagocytose the damaged stuff, which again, we'd see then increased local macrophages, the microglial cells. Over 1 to 2 weeks, we see this reactive gliosis, which we see astrocytes proliferate, glial cells become enlarged, our vascular perforation or proliferation occurs at peripheral sites to the necrosis to start to try to bring healing cells to heal the area. And 2 or more weeks, we'll see really dense astrocytic processes surrounding the cavity of the necrotic debris, and there'll be cystic spaces that are surrounded by some glial cells and scarring. An ischemic CVA is often due to a thrombosis or an atherosclerotic plaque that leads to vessel occlusion. You can have an embolotic. We think of AFib as being one of the causes here, 5 times more likely to lead to stroke. Bacterial endocarditis could. And it's going to affect the following pretty classically: middle cerebral as the greatest, anterior communicating, and then posterior communicating. You could see a hypoperfusion globally. The hippocampus is vulnerable to hypoxia, so that'd be an area of note. And under autopsy, you would see a wedge appearing area of necrosis to bilateral sides. A TIA or a transient ischemic attack is where you see focal neurologic deficits, but there's no tissue infarction and a normal image. And this would typically resolve on its own within 24 hours. Looking at the lenticulostriate artery, a stroke in this area will affect some key structures: the basal ganglia, the internal capsule, the posterior limb aspect, and the cerebellum. For the basal ganglia, you would see symptoms like chorea, tremor, bradykinesia, rigidity, and altered behavior, almost what you could see in a Parkinsonian presentation. The internal capsule, the posterior limb, will present as a contralateral opposite side hemiparesis and sensory impairment. Looking at this stroke, it is oftentimes number one caused by chronic unmanaged hypertension. You can see an infarction to the lacunar area, which is due to a hypertensive arteriolar sclerosis. You could see potentially a microatheroma, which is a lipid-laden macrophage accumulation at these branch points, or a lipohyalinosis, which these are foamy macrophages that lead to thickening of a vascular wall. Hemorrhage could potentially occur. This would be due to hypertensive vasculopathy, and we see this more with our Charcot-Bouchard aneurysms. A lacunar stroke, the internal capsule posterior limb is the most common form. We can see kind of some mixed presentation. So if there's a pure motor, we have contralateral upper and lower extremity and face effects. We oftentimes think of the posterior limb of the internal capsule as the most common etiology. Pure sensory, contralateral upper and lower extremity and face. We often think ventro posterior lateral and or ventro posterior medial thalamus, or the posterior limb of the internal capsule, but that's more rare. Mixed sensory motor with contralateral upper and lower extremity and face involvement, the posterior limb of the internal capsule is common. And hemiballismus is contralateral involuntary large flinging movements of extremities. We think of the subthalamic nucleus. I mentioned in the middle cerebral artery stroke, again, structures that would be affected here would be the frontal region, frontal lobe, primary motor cortex, Broca's area, and frontal eye fields. Temporal, like Wernicke's area, parietal, the angular gyrus, and optic radiations. In a middle cerebral artery stroke, in the frontal lobe or primary motor cortex could lead to the presentation of contralateral upper extremity and lower face motor and sensory impairment. We also could see with Broca's area being involved, non-fluent aphasia, expressive aphasia. Essentially, you know words, but you're not able to speak them appropriately. And frontal eye fields, you'll see a conjugate deviation to this towards the side of the lesion. Our middle cerebral artery or stroke in the temporal area, we could see Wernicke's region being affected, which would lead to fluent aphasia, where the patient is able to speak, but the words are nonsense words. In the parietal region, the angular gyrus could lead to Gerstmann syndrome. The non-dominant lobe could lead to a contralateral hemi-neglect, and optic radiations leads to those visual defects that we saw earlier, contralateral homonymous heminopnea or quadrantenopnea. Hemi, think of half, and quadrant, think of a quarter. If we have an anterior cerebral artery stroke, the structures that can be affected is our anterior medial primary motor and sensory cortex. We'll see a contralateral lower extremity motor and sensory impairment, potentially bilateral urinary incontinence, and altered behavior. In a posterior cerebral artery stroke, we'll see occipital regions like the primary visual cortex being affected, and that leads to a contralateral homonymous hemanopnea with macular sparing of the macula densa. In an anterior inferior cerebellar artery stroke, this is also called lateral pontine syndrome, and you have issues with certain cranial nerves like 7 and 8. So you'll have facial muscle weakness, hyperacusis, loss of anterior two-thirds of taste. You could see vertigo, nystagmus, and hearing loss. And if lateral tracts are affected, you could see the loss of temperature and pain sensation to the same side of the face and opposite side of the trunk and limbs. You could also see same-site ataxia, dysmetria, and dysdiadochokinesia. Our sympathetic or lateral tract, if it's affected, you could see a Horner syndrome ipsilaterally, same side with mitosis, ptosis, and anhidrosis. A posterior inferior cerebellar artery stroke is lateral medullary or Wallenberg syndrome, where cranial nerve 8 can lead to vertigo, nystagmus, and hearing loss, cranial nerves 9 and 10 leading to dysphagia, dysphonia, and impaired gag reflex. The lateral tracts present the same, and the sympathetic or lateral tract, if affected, presents the same. An anterior spinal artery stroke could lead to medial medullary or Dejerine syndrome and cranial nerve 7 with ipsilateral tongue palsy, deviation to the side, same side of the lesion, can occur. If medial tracts are affected, you could see contralateral opposite side weakness of the limbs and a loss of vibration or proprioception. In a vertebral artery stroke, this could present with medial medullary or Dejerine syndrome or lateral medullary Wallenberg syndrome. With a basilar artery stroke, you could see bilateral ventral pontine arteries being affected. The structures would be the ventral pons, and you'd present with a quadriparesis, a horizontal gaze palsy, where your vertical eye movements and blinking are intact. You can't move side to side. And arthria, dysphagia, and Cheyne-Stokes respirations. You can see also a locked-in syndrome here, which is a rapid overcorrecting of chronic low sodium hyponatremia, where you see central pontine myelinosis and or myelinolysis, essentially disruption of myelin, and an osmotic demyelination syndrome. All right, we will stop here and then we'll come back and look at some aneurysms.